Thank you for the opportunity to present some of our work here today.
Yeah, and you push that with
Thank
your
you.
mouse.
So I have no relevant disclosures, but this work was supported by a research grant from the FES committee. So as we know, endoscopy has become a mainstay in general surgery practice. We know that the number of cases being performed by surgeons nationwide has doubled over the past few years, that it's one of the most common types of procedures being done by rural surgeons, and that residents are doing endoscopy now more than ever. So this increased prevalence has really focused attention on the way that we're training and assessing surgeons to perform these procedures. In fact, the American Board of Surgery has recently instituted a requirement that general surgery programs implement a focused curriculum for flexible endoscopy. And this consists of didactic, simulation, clinical assessments, as well as a final milestone of passing the FES exam, which consists of both a cognitive portion as well as a manual skills portion. What we don't know, though, is how our current curricula it impacts the extent to which residents can succeed on this exam. So we designed a study with 3 overarching goals. First, we wanted to know how are our trainees currently performing on the FES exam, if we change nothing. Second, we wanted to know the relationship between experience, as measured by ACGME case logs, and exam scores. And then finally, we really wanted to better understand which curricular components are going to be most successful to equip our residents with the skills needed to pass this exam. So to achieve these aims, we invited general surgery residents, PGY5s nearing graduation, as well as GI fellows from our Texas Consortium of Surgical Skills Labs to take the FES exam. And we specifically instructed them not to study, not to practice on any simulators, just come in and take it cold. And for those who chose to participate, we obtained their case logs from their program directors and also collected the curricular components from their respective institutions. So what does their skills curricula look like? Do they have any cognitive curricula? And what do their rotations look like? Is there a dedicated endoscopy rotation? So here's what we found. We had 6 programs across Texas participate. We had 28 PGY5s participate, as well as 20 GI fellows of all different levels. And what you see here is the average number of case logs being performed by these residents and fellows. So for BGY5s, they reported an average of 45 EGDs, 76 lowers, as well for an overall average of 128. And then we have it broken down for our GI fellows, the case logs by year. And I will say that the case logs reported were a little unsystematic, as you see by some of these really high standard deviations. They're a little bit all over the place. In regards to passing the FES exam, again, we have it broken down by specialty and year. Our general surgery residents, those 28 PGY5s who had otherwise met all curricular components and were about to go into practice, only 68% of those residents actually passed both portions of the exam. And they failed both components. So 86% passed the cognitive and 75% were able to pass the skills portion of the exam. For the GI fellows, you'll see that they all passed the cognitive portion of the exam, but there were actually 2 first-year GI fellows as well as 1 third-year GI fellow who failed the skills portion. And I think it's worth mentioning that there are 5 tasks on the actual skills portion. The most challenging task for all participants was the task 2, loop reduction. In fact, 11 individuals earned a score of 0, so 8 residents, 3 GI fellows. And the highest score was that task 5 by manual targeting. We also wanted to examine the relationship between experience and ability to pass this exam. So for our surgery residents here on the left, there was no significant relationship between experience, as measured by these case logs, and performance on the cognitive portion of the exam. But if you look at the skills component of the exam, lower endoscopy really predicted success for that manual skills portion, such that more colonoscopies you have, the more likely you are to pass that portion of the exam. For GI fellows, though, there were no significant relationships. We also performed ROC analyses to see if we could identify a threshold that would allow us to reliably predict examinees passing both parts of the exam based on their case log data. So if you look at just the left portion here, it's looking at total number of cases. So for general surgery trainees, about 103 total cases were required in the sample to pass just the manual portion of exam, And again, that number popped up similarly for passing both portions of the exam. But because the number of colonoscopies was so highly correlated with being able to pass the manual portion of the exam, we looked at just the number of lower cases. And as you see, it required about 60 colonoscopies to pass the manual portion of this exam, and about 63 just to pass total. And for those of you who are very involved in residency programs or program directors yourself, you'll likely know that the RRC requirements for endoscopy cases is 50 lowers and 85 total. So you'll see it's a little bit higher here. And then finally, one major thing we wanted to pull from this was to really identify which curricular components impact success on this exam. So we have each institution listed here, and it's a lot of data, but we have in the first few columns the FES pass rates broken down by cognitive skills total. As you see, every program who participated had to require simulation skills curricula, and most of which had a formal cognitive curriculum instituted as well, so using SCORE or some other resource there. Only a third of the programs had a required endoscopy rotation, both of which actually rotated with GI. And on this right portion, you'll see what the simulation skills curricula involved. So almost everyone, a majority of the skills curricula that they instituted required training on the VR simulator, which again is the testing format for FES. And then a lot of the other curricular components involved inanimate simulators and some tissue simulators as well. So what does this tell us? First, it tells us that there's wide variability as measured by the FES exam and the competency among current graduating general surgery residents, as indicated by that 68% overall pass rate on the FES exam. And again, there were failures in both the cognitive and skills portion. Some of the ROC analysis really bring up a conversation of, if we go by just the minimums required from the RRC, is that really enough? Because of course it's only one venue for training these skills and probably a rough measurement of experience, but our data suggests that something more along the lines of 60 lowers and at least 100 total cases would be a more reliable predictor of success. And then finally, it really supports the development and implementation of the FEC, the actual curriculum that programs are starting to implement. And for those of you who were at the educators luncheon earlier today, it all revolved around FEC and FES. And if you were there, you were lucky enough to hear that there is a lot of ongoing development in terms of curricula and proficiency-based training modules and simulators. So for those of you who are program directors, I don't think you should be too worried about this because the requisite support and established curricula is being developed and ongoing. So again, I thank you for your time.